Hello. Thank you for having me here today. I'd like to extend an apology that I'm not able to present this live, but unfortunately I had a last minute scheduling conflict, which means I've had to pre-record this, but I'm sure we'll get just as much value from this as if I was here presenting live on Teams. My name is Neil Gardner. Anyone who might spot a family resemblance, who knows Alan? I'm Alan's brother. I've been a radiographer for almost 20 years, and I've been reporting plain film chest x-rays, abdomen x-rays and MSK since about 2011. So today I'm going to be presenting this presentation, an introduction to the chest x-ray. This is a presentation that has evolved. This isn't the first time that I've presented at UCLan on this topic, but this is a progression of a presentation that has been developed at UCLan and has had my input in as well. So as I say, I've been a radiographer for a while, an advanced practitioner since 2011. Spent many years working in and around West Yorkshire, Mid Yorkshire, worked at Bradford Teaching Hospitals, where I eventually ended up as the superintendent there, and I currently work outside of the NHS as an advanced practitioner, and do things like guest lecture at different institutions. I do have a special interest in the chest x-ray. It's been a core piece of my practice for many years, and I think it's a really interesting subject. So before we crack into death by PowerPoint, I suppose, what do we really want to get out of today's presentation? Well, I'm sure if past cohorts have been anything to go by, I'm probably talking to a quite wide spectrum of healthcare professionals. I know previously we've had trainee nurse advanced practitioners, paramedics, I think we've also had some physiotherapists and OTs. So lots of different people who are going to come into contact with chest x-rays over the course of their practice, and engage in dialogue and conversation with radiology. So what's really important is to have an awareness of the normal appearance of a chest radiograph. Because we're going to be talking about image analysis and pattern recognition, being able to know what's normal is really, really important. I'd like you all to gain some understanding of the complexity of image interpretation. I think quite often, especially when it comes to kind of plain film or conventional radiographs, there's not so much a stigma, but a kind of thought that, oh, well, it's only an x-ray. It's not one of these, sexy cross-sectional imaging modalities. But there's a lot to be said for the complexity of image interpretation, because what we're doing essentially is we're trying to assess a three-dimensional structure from a two-dimensional image. And so there are things that we need to consider and think about before we make any judgments. And of course, the person who has made a career out of doing that is going to tell you that it's complex and important. But believe me. And then we're going to acquire some visual experience with radiographic images and talk about what we're looking at, or what we can understand by the image in front of us, and what conclusions we can make from that. So I think a really important place to start is having an appreciation of how a chest x-ray is taken. And I know that probably many of you have escorted patients down to the x-ray department, or possibly even spent some time as students there. But a lot of the time, patients leave the ward or the department, they go off down to radiology, they have their x-ray and they come back again, and then an image is presented on packs for us to view. But I just thought it's important for some of the things that we'll talk about later on to have an understanding of how the X-ray is taken. So here we can see we have a patient stood for a chest X-ray at a wall stand. And this is what we call standard projection, with the patient facing towards the detector. Back in the day, it would have been a film, but everyone uses digital now, so it's the detector, and we have the X-ray tube here with X-rays, in this graphical representation, being emitted from the X-ray tube to the patient, passing through the patient, and hitting the detector. And it's no coincidence that we've got the light beam diaphragm here showing the radiographer where the X-ray will be taken, and we're coming from the X-ray tube in divergent rays, and that's a really important thing to talk about shortly. So, as I say, in conventional radiography, the detector's placed beneath the area of interest, in this case the chest, and a couple of, just in case I slip into acronyms later on, so CR, you may have seen around, computed radiography, onto an image receptor. When we moved away from film, these were still a physical image sheet that was then read by a computer, and these days in DR it's digital radiography, so it's onto a detector, much like digital photography. And these days, rather than getting a piece of film out of either a processor or from a wet process, we now get an image digitally on packs. The keen-eyed amongst you may have noticed that this patient is wearing a little bit of lead shielding. That's just to protect some of the more radiosensitive organs of the body, made out of the same material as the lead aprons that some of you may have worn in theatre, just to ensure that although all images obtained for medical purposes using ionizing radiation need to be justified, there's still a benefit risk balance between what's necessary and unnecessary when risk is involved. So adding any lead protection when necessary and appropriate is best practice. We can also see here that we've got very good practice of the patient being positioned with the arms out. If you can see from here, arms out, and that's what that's doing is bringing the scapula away from the lung fields, so we have a really good view of the upper zones and the apices, and again, something that we're going to talk about later on in the presentation with regards to understanding normal and best practice. So what are we actually seeing on an X-ray? I know obviously we're seeing anatomy, but an X-ray image is produced as a result of the X-rays either passing through the patient, or the piece of anatomy that we're looking at, or being absorbed by the body. So where the radiation passes through the patient, we see black areas. So here the air in the lungs, because there's nothing to attenuate or absorb the radiation, so it just passes through and goes onto the imaging detector. And where the areas are white, then the X-rays are being absorbed and not reaching through to the detector. So we have these areas of white and the whole spectrum of grey in between, depending on the amount of absorption or attenuation that's been achieved by the different the composition of the area that we're imaging. And it's important to understand those concepts, because as well as looking at X-ray images as part of your practice, it's really important that you understand some of the technical both limitations and issues that can arise during or when looking at an X-ray. And that's not to say that you're not radiographers, we're not teaching you how to report, but by having an understanding of some of the techniques and some of the factors involved with image interpretation, you can have a better dialogue with your radiology departments, because it's easy to have a conversation about something like this, that's a technical, you need technical understanding, that conversation is facilitated and is a lot easier to have if you have a level of understanding that, and you can have those conversations rather than ring up the X-ray department and go, this chest X-ray looks a bit funny. If it's overexposed, so you're losing some of the finer kind of parenchymal architecture of the lungs, and all you're seeing is black. Without that knowledge, you could look at it and go, well, it's all black, it looks fine. But actually, if you understand that, I'm not seeing the detail that I need to, and I think it's because it's overexposed, as in the X-rays have penetrated the body too much and burnt out those finer details, then that facilitates a more constructive conversation with radiology. So, the keen-eyed among you will notice that this is not a chest X-ray. What we have here is an abdominal X-ray, but it's useful just to show the different densities that can be seen on radiographic imaging. So, as we said previously, like you see in the lungs, black tends to be air in the lungs there, but also here we can see air in the bowel. Fat tends to show up dark grey, so it easily seen in the abdomen. Light grey, more soft tissue, and if I click back to the chest X-ray, lighter grey being all the soft tissues of the chest wall here and in the subdiaphragmatic region. It's described here as dull white. Again, this isn't my slide, but I did think it was a good one to leave in. So dull white bone, and we can see a brighter white here, and this is a contrast medium because this particular abdominal image is they've used contrast as part of a intravenous urogram or an IVU. Not something that we see a lot of these days, as the things tend to have moved on, and we use CT a bit more often now. And there's just another few examples here of the difference between the different densities of a regular plain film image, the use of some contrast medium in the renal system, and then the contrast between the bright white and the dark black of air and contrast within the bowel. So, swiftly back onto the chest X-ray. So, what do we need to be seeing? So, it's providing an image of the organs and structures within the chest. And what we should be seeing on a chest X-ray is everything from above the apices, or the top of the lungs with the soft tissues, the heart, the mediastinum, both lungs, all the way down to the costophrenic angles, the top of the abdomen, so this kind of subdiaphragmatic region. We're seeing the major pulmonary blood vessels and the bony thorax. If for whatever reason, whether they've been collimated off, probably should have mentioned that earlier, but collimation being where the radiographer would use the light beam diaphragm to project onto the patient as if by magic. Here we adjust twiddle the little knobs, and the light projects on the patient. We refer to this as collimation. So if I use that term further on in the presentation without thinking, just because it's part of our everyday vocabulary, then that's what I'm talking about. So we're going to move on shortly to the topic of having an appreciation of normal. But viewing an image, as I'm sure many, if not all of you, will continue to do in your practice, starts before you even look at the anatomy. And it's really important to have a systematic approach to image interpretation or analysis of the image that's been provided to you. And that starts by, and it sounds really simple and really silly to bring up, but making sure you're looking at the right patient. How many times I'm sure people have looked at notes on the ward. It happens in radiology all the time. Someone's clicked the wrong button, or someone has brought up the wrong details. It might be a very similar name, a very similar date of birth, a similar time of attendance, and you've got the wrong details. So already there, we're setting ourselves up to fail. So we need to make sure that we're looking at the right patient ID, and especially these days with everything becoming digital, and whether you're using an EPR, electronic patient record system. I don't know if any of you have used Cerner, or if any of you are from the Northwest, you've got the MFT using Hive/Epic these days. Making sure that we've got the correct patient details, we're looking at the right patient, and also we're looking at the right date of imaging. So a patient, maybe an inpatient, they may have attended through A&E, they may have ended up on a different ward, they may have gone to high dependency or ICU, come to wherever you are, and they may have had multiple imaging instances throughout their journey, and you need to ensure that you're looking at the most current or the most relevant one for you. And then what we need to look at is anatomical marker. So by anatomical marker, I mean you'll often see these little L's or R's denoting the left or right side of the patient. And it's not the fact that this is recorded or flipped around, and I'm sure some of you will know, but some people may be unaware, that we're viewing the x-rays as if the patient is looking at you. So that is the left-hand side of the patient, even though we've taken the x-ray predominantly in the standard projection in this PA, or posterior anterior. So the x-rays are projected from the posterior of the patient through to the anterior. And again here we've got a little R. And I know that these are PA images because that's our standard projection, and so there's no other indication on there to show me that it may be AP. So anterior posterior projection, so the x-rays have passed through the front of the patient. Again, that's something we're going to talk about further on in the presentation, and the importance of knowing which one's which. So once we've got all of these nailed down, and we know that we're looking at the right patient, the correct image for the time that we think we're looking at, and we have an appreciation of the anatomical marker, because then that tells us something about how the x-ray was taken, then we can move on to our systematic approach to reviewing the x-ray. So once we've decided that we're looking at the right patient, the right timing of imaging, and we have an appreciation of how it's been taken by looking at the anatomical marker, we need to have a bit of a mental checklist to make sure that actually what's on the image is everything that we need. And like we said previously, we should be viewing from the soft tissues above the chest. This is not my slide, and it's a little bit tight up here. I would like a little bit more, but we'll see some really good examples shortly. But we need to make sure that we're seeing all of the lung fields, and look at the volumes and the positioning and the opacity of the lungs. Something that we're going to talk about shortly, but we again, having that understanding of normal, and then being able to make assessments of what we're looking at as to what the abnormality is. So we've got nice clear lung field. We need to make sure that we've got all of the lung fields from the apices all the way down to the costophrenic angles. We need to make sure that we're seeing the hilar regions, and that we're not, they're not obscured by anything, that we can see them. We're assessing the heart, both for its positioning and size, the mediastinum. We need to be able to make sure we're seeing both diaphragms or diaphragmatic borders all the way down to from the cardiophrenic angles all the way down to the costophrenic recesses. We're assessing a central trachea, and we're also looking at bones, something that's often quite overlooked when people are looking at chest x-rays, because we're thinking heart, lungs, but the bones are really important as well, especially if the patient has pain post-trauma. What if it's not trauma? Maybe there's some bony pain in the thorax. It's something that can't be overlooked. And then these are some highlighted areas of anatomy. Just I know the slide makes it look like they're bones, but they're not. We've got the SVC running down the mediastinum, aortic arch on this side, unless you've got an anatomical variant. Pulmonary arteries either side of the hilar structures, the right atrium, left ventricle, and the diaphragms here. And then we've got a little gastric bubble and the liver, which is, again, as we said before about the different attenuations or the absorptions of x-rays, we've got nice clear black lungs, and then the liver, because it's a soft tissue, density is white underneath the diaphragm, because we've not the X-ray radiation hasn't been allowed to pass through the liver because it's dense soft tissue structure, so it's not, the radiation hasn't made its way through to the detector. And here we have another annotated chest X-ray, just showing some other there's some similar annotations, but there's also some slightly different ones. So you go and with a graphical representation over the top, because sometimes, especially when you're first looking at X-rays and chest X-rays in specifically here, people can be pointing things out, and you look at going, oh no, okay, yeah, I mean, it just looks like a lot of grey and black to me. But having these graphical representations over the top can really help. So yeah, SVC, the right main bronchus, so the trachea coming down, splitting into the left and right main bronchus. They've got a graphical representation over the horizontal fissure, and we'll have a little bit of a chat later on about the different lobes and zones of the lungs. I'll leave this on here, just you'll be able to pause this later on and have a look. And then we've got another, again, graphical representation of a chest X-ray, which again points out some structures, and the same here. And you'll be able to find lots of these online if you so wish. So we're going to pause just here on what I tend to think is a really good representation of a very well positioned, well taken chest X-ray. So let's take everything that we've just talked about and apply it here. So what we're looking at, obviously this is just an example X-ray, so don't have the patient's name. Let's presume it's the correct patient and it's the correct time. We've got a right here, so I know that this X-ray was therefore taken PA, because there's no other annotations on here to tell me otherwise. And that's something that you can expect as a standard from radiology, that if they've taken any X-ray outside of what's considered the standard protocol, the standard procedure, which for a chest X-ray is PA is the standard, that they'll tell you by putting an annotation on the image. So you'll often see AP lateral. I'd like to think that you'd all be able to spot that a lateral is taken lateral, because they're very different, but AP and PA can look similar, but we're going to talk about the differences and what those differences mean later on. So we've got a very well positioned patient, and we can tell that because we have the medial ends of the clavicles are equidistant to the spinous processes of the vertebrae. So we've got the patient up against the detector in a good position, and they're not rotated left or right. And we'd be able to tell that because we'd then have a clavicle over here, a clavicle over here, and the spinous processes wouldn't be equidistant between. We can see the vertebral bodies here. So it's very well positioned. We can tell that the patient had their arms in a good position, getting their scapula out of the way of the lung fields, because we can just see the outline of the scapulas here on the peripheral regions of the lung fields, so they're not obscuring any of the details of the lungs. We've got nice clear lungs. We've got no big areas of white or black. We've just got nice lung fields, and we can count the ribs. We can either count them anteriorly, 1, 2, 3, 5, 6, 7, 8, just seeing it there, or posteriorly, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We got nice good inspiration. So you may have noticed it when if you've seen a patient be x-rayed, or if you've been x-rayed yourself, just take a nice big breath in, fill the lungs full of air, so we get a good visualization of the lungs. We've got good collimation, so we are seeing the soft tissues above the apices, and we are seeing the lateral soft tissue borders of the chest wall, the subdiaphragmatic region, and we're seeing all the structures that we've talked about previously. So this is a good place to start, where we can now understand what normal looks like and what a well-positioned X-ray, chest X-ray looks like. So this is a good place to start from. Before we start discussing other kind of issues of technique or pathology, just thought it'd be good to go through a couple of technical terms. So we although the lungs are obviously in lobes, we've got 2 lobes on the left, 3 lobes on the right, difficult to see to either the untrained eye or even sometimes the trained eye. So we tend to discuss the lungs in zones. So we tend to describe upper, mid and lower zones, both either left or right. And there's just a couple of graphical representations here. Some of the useful terms to understand, and you'll often read them in radiology reports. Opacity, opacification, lucency, so whether things are white or black. Blunting, because we like to describe in radiology the how things look compared to how they should be. So if something is meant to be nice and crisp, like a costophrenic angle, but all of a sudden it's blunted by a pleural effusion, we'll use that term. Atelectasis being a small area of